And yep, I concierge the antibiotics. The concierge still just follow them. I did for me there so and then just follow up on the leaky valve, see what they said. Okay. Basically that's it. I think because everything Mary and all the follow-ups. Okay, that's it. Okay. All right. I'm actually gonna.
Good afternoon, everybody.
Horrible person.
Are you able to hear me well? Good. My name is Bandana Padyal Nepal. I'm the new faculty for pediatric nephrology, and I was asked to talk about sodium disorders. And we will talk today about hyponatremia, hypernatremia, pathophysiology, how things are regulated, and towards the end of the day, probably we'll know how to manage those cases as well. When we talk about salt disorder, we always have to take in account of water because they, go parallelly. Total body water, body is full of water. So when we talk about preterm infants, probably 80 to 90% of their body weight is water. Term infant, 70 to 75. When you reach puberty, 60%. And like if we talk about the adults, more body fat portion, like your body weight goes down. So females have less body fluid than the males, and extracellular fluid, it will be 1/3 of that water, and intracellular would be 2/3. And when it comes to extracellular fluid, 2/3 is in the interstitial compartment and 1/3 intravascular compartment. Sodium is a major extracellular cation, and water will move freely to balance the osmolalities. Therefore, all the compartments have equal osmolalities. The total amount of sodium in extracellular fluid is the major determinant of the size of the extracellular volume. If sodium increases, the volume should increase. The example, like somebody who comes edematous, like they're in heart failure, liver cirrhosis, nephrotic syndrome, you see the total body sodium and extracellular fluid compartment has increased, and they have total body fluid, much more higher than normal. And if there is too little sodium in the extracellular fluid, then the extracellular volume will deplete. What regulates the extracellular, fluid volume? The kidney will control by controlling the sodium excretion via renin-angiotensin and aldosterone axis, atrial natriuretic protein axis, and sympathetic nervous system. So ultimately, with this, kidney will try to excrete if there is excess sodium and maintain the volume normal. And there's something called tonicity, tonicity of the extracellular fluid. It is mediated by vasopressin secretion and the thirst mechanism. Hi there. So here we, I wanted to project this. So basically, normal osmolality, the plasma osmolality, when we reach around 280 and beyond, that's when the ADH secretion will come in. And when you reach around 290, that means, plasma is hyperosmolar, then you're thirsty, you start drinking, and, you have the ADH, action there, and you conserve water, and then you bring that osmolality towards normal. So water is being conserved in the body. So that's the normal mechanism. And as the vasopressin level increases, your urine osmolality will keep on increasing and maximize. Osmolality versus tonicity. I think these two terminology we need to know. Osmolality is total solute concentration in the fluid compartment. What is the total solute concentration? Tonicity, it's a combinability of the solutes to produce the osmotic driving force that causes the water to move from one compartment to the other. And that the control of the tonicity will determine the normal state of cellular hydration and the cellular size. And this is a particular concern in case of brain cells. And plasma osmolality, so this is how we would, calculate the plasma osmolality. We all know it will account the sodium, glucose, and the BUN. And when you measure these molecules in milligram per deciliter, you have this denominator of 18 and 2.8. If you are doing in millimole, then you just, just go without those numbers, okay? And sodium and glucose, those are the solute, they do not cross the cells just freely, but if you account the urea, it will just go everywhere, right? So, it just moves. So that's why it is an ineffective solute, whereas sodium and glucose, those are more of an effective solute that will maintain the, tonicity and all that, right? Plasma tonicity, it is the effective plasma osmolality in other term. So is the parameter sensed by the osmoreceptors and determines the transcellular distribution of the water. So water can freely, move, right? So when there is more water and, water will move from higher of that water to the higher concentration of the solute, right? So they maintain that, equilibrium. And plasma tonicity is 2 times sodium plus the glucose. Here, we don't have that urea because urea crosses over both sides, right? So that's not the one which will give you the tonicity. And there's something called water excretion. So what regulates the water excretion and all that, right? To regulate the water excretion and keep the tonicity, which is the sodium concentration in the extracellular volume, there must be things that are always constant, right? Your GFR should be normal. Your delivery of the glomerular filtration to the concentrating and diluting segment of the tubule should be normal. And there should be intact concentrating and diluting mechanism, and there should be appropriate turning on and turning off of that ADH response. And the ADH should be acting normally to the kidneys. If all these things are in balance, then you have that normal regulation of water. If anything goes wrong, then your water system is broken and you tend to cause the problem with the sodium disorders. Now the excretion of free water. So if you see, this is the nephron segment, and when the filtration, right, when you have that plasma is being filtered, you have this 285 in the proximal tubule. As they go in at the depth of the loop of Henle, you're very concentrated because you're observing the here water, and then as you move up, the salt is being observed in the ascending loop of Henle. And when you reach the distal segment, you have the dilute urine, and as you go down, then ADH comes in, and then it will conserve the water, and some amount of salt will be exchanged, but more so water will be conserved, and you have the very concentrated urine there, right? So if you have a lot of ADH, then you have very concentrated urine. You don't have ADH, then you basically dump all the dilute urine. So what causes all these problems is basically when you don't excrete as much as you want to, or you're retaining more than what you want to, then you encounter the problems. So hyponatremia is primarily due to intake of water that cannot be excreted. Hyponatremia, when you lose more water than the solute, then your sodium is high. And hypovolemia, you're losing both water and the water together. And edema is when you're retaining sodium and the water. So hyponatremia, your plasma tonicity and osmolality both are low. Hyponatremia, same thing, osmolality and tonicities are high. In uremia, somebody comes in with BUN of 200, if you calculate, it seems like, oh, plasma osmolality is high. Now, you want to dialyze them, can you just wash out all that urea? Yes, you can, but would they be okay afterwards? Not really, right? We always worry about disequilibrium because urea just, passes. And then, what happens is when during that time, your tonicity, somewhere there, you want to maintain that, because if you don't maintain, then brain edema occurs, right? So from the blood, you're removing a lot, but then at the same time, the brain adaptation for that urea, it's slower. So, you basically your disequilibrium comes in because, that is not washed out and you're absorbing water, and, that that's the main mechanism there. So hyponatremia, sodium, when it is less than 135, then you call it hyponatremia. It is because of excess water retention. And typically kidney will excrete as much, like you drink a lot, you pee a lot, and you don't drink, then kidney will conserve. So if your kidneys are not doing job, or you chug like almost 10 liters of water at a time, then kidneys are overwhelmed. So then you're not able to maintain that equilibrium. Here, excretion of free water, right? So suppose, like you're diminishing the generation of free water in loop of Henle or distal tubule. Suppose your filtration, like, you're in renal failure, you're not filtering as much, right? Your filtration fraction is already low. So whatever is coming in the tubules, like you're not washing out, and body is retaining a lot of fluid. Or you're hypovolemic, somebody's losing blood, and, the body doesn't have as much to filter out. So your GFR is cut down and you're not filtering as much. And if you do the diuretic, suppose you're doing the loop diuretic, then you're knocking down, and then, or if you're doing the thiazide diuretic, you're knocking down the distal tubule. So then you have the highly osmolar load coming to the kidney, and then, basically that will go out, and, it will basically diminish the free water excretion there. And suppose you have this unnecessarily high ADH, then that will basically conserve the water, right? So you're conserving much more than needed water, then that will lead to water retention and hyponatremia. So impairment of renal water excretion, so that happens when you're using the diuretic, because you're knocking down the system which balances the sodium and chloride. At the same time, you're excreting, you're not excreting as much of the free water. And same thing, with the dehydration too, you have a lot of ADH, and as such you're not filtering as much maybe, and then ADH will come in, and then that will conserve. And somebody who drinks a lot of beer, your solid load is low, so that's also. And older people, they just or vegetarian, they can be the same one. They don't eat as much protein load, so their solute load is low, so they also have hyponatremia easily. And if you drink a lot, then kidneys are overwhelmed and it's not able to excrete as much. So causes of hyponatremia, so you can divide among, with the hypovolemia, normovolemia, or hypervolemia, or apparent, hyponatremia status, right? So if you are losing like GI or through the kidneys with the diuretic, or cerebral salt wasting, or skin losses, especially cystic fibrosis kids, right? They lose a lot of chloride and sodium in the skin, and mineralocorticoid defect, and salt wasting, other nephropathies. And when you're hypervolemic or normovolemic, especially like renal failure, you're retaining more water. SIDH, that's inappropriate, so you're retaining more fluid, water intoxication, nephrotic syndrome, cirrhosis, even hypothyroidism, and glucocorticoid deficiency, and congestive heart failure, those. And sometimes you see all these DK kids coming in, their sugars are high, and hyperlipidemia not as much, or hyperproteinemia, like we'll go and I'll show you the calculation, but especially hyperglycemia can give you this factitious hyponatremia. The symptoms, they might be, like if sodium is 125 to 130, they might be just complaining, oh, I don't feel well, nausea, just fatigability. But then as the sodium decreases, the headache, lethargy, sometimes even obtundation, seizures, coma can come in, and they can have respiratory arrest as well. And they can end up with non-cardiogenic pulmonary edema. So that symptoms usually arises when you are less than 125, and it all depends on how soon that dilution happened too. So here, this is from one of the textbook. I could not find it in online version, so I had to take the picture and put it here. If you see the brain water and how the plasma sodium and how soon that decrease. So this is the normal, right? And the if you see the second one, the tall, the bracket here. So from plasma sodium dropped from 139 to 119 within 2 hours. When that happened, your brain absorbs so much of water, like the brain, like almost 17% of the normal. So all of a sudden they had the severe brain edema and then they just died. So that could, it just, this is from one of the study, quoted. And if that was over several days, right, from 140 to 122, like it took 3.5 days, then you had the slower, brain swelling, like meaning water adaptation. And when it was over 16 days, then it was slower. So it was pretty equivalent, right? 3.5 days to 16 days. But you see the 139 to even 99, that over 16 days, they didn't have much of that, brain edema, because there was enough time for the brain to adapt. The brain edema, if something like all of a sudden, your brain is edematous, then that can give you all this reflex phenomenon, because, that can lead to pulmonary edema, catecholamine release, and other, reflexes. Some of some of the mechanisms are more complex, but that can happen. That's why, like, you go into, respiratory arrest. And so too rapid, right? Over 1 to 3 days or over several hours, that can happen, as an error. Sometime you might be thinking like you're hanging D5 normal saline, but then, like it's not that solution. Sometimes errors can happen. So, or sometime, like somebody wrote it and then they're writing the hypertonic solution and large amount, especially post-op, right? They might be bleeding, and then they might get something hypertonic as a resuscitation, or they're getting lots of fluid for the burn patients, or patients they're just chugging, they might be chugging lots of fluid, and that can rapidly, lower your sodium concentration. And development of cerebral edema is dependent on the transfer of water from plasma to the CSF and into the brain. So here this is the glial cell, and this is basically blood-brain barrier. So the inside, that's endothelium, and outside, that's the end foot of that glial cell. And if you see sodium potassium ATPase is the round one, and the oval one is the echophorin 4, which will transport the water, and that KIR is inwardly rectifying potassium channel. So they basically monitor the sodium, water going into the cells. So the glial cell, it's permeable, so it's now swollen, right? This was from one of the mice study, where what they did is they knocked down that echophorin 4, and they tried to correct that. So, like they were just depleting the sodium, and they wanted to see how much is the brain edema. So when they knocked that echophorin 4, there was not much of brain edema. So they were not swollen as much to the one which had the normal echophorin. So the diagnosis, somebody walks in, they're vomiting, they have diarrhea, or they were on diuretic therapy. So it's easy, right? You know what's going on. And on exam, you might see the signs of dehydration, right? You just recently had the lecture on dehydration and how to correct that. Or there might be edematous. Sometimes the demarcation with euvolemia and dehydration, if they're mildly dry, it's really hard to say, but you will know if they're truly depleted or edematous. And you will do the labs, the initial labs, kidney function, you calculate, you can send for measuring the osmolality, or you can calculate it bedside, and you will check the urine osmolalities and, urine electrolytes. And sometimes you have to see whether this is pseudohyponatremia, or, is it truly low, or is it, low. And normal serum osmolality 275 to 290, and this will be reduced in hyponatremic patients. And I included the serum osmolality here as well again. And hyponatremia, suppose, if you're truly hyponatremic, the body has to, normal response for kidney would be to conserve that, salt, and, if you're hypovolemic, you conserve the water, right? So when you are, like you're depleted on the sodium, but at the same time, kidney is trying to get rid of the sodium, something is wrong there, right? It's not the normal response. So if you determine like, your urine osmolality is higher than 100, that means there's impaired water excretion. So hyponatremia with the urine sodium concentration, suppose, just plain sodium, like you look at the sodium and it's truly like less than 20 or less than 25, that means you're dry, your body is trying to conserve it. And if it is more than 40, that's not right because, kidney should be conserving the salt, but it's trying to get rid. So it could be one of the reasons, it could be acidosis or kidney is not able to conserve, which happens with renal failure, or you're on diuretic or adrenal insufficiency, or, like one of those reasons. And sometimes, it's easier to calculate FeNA, but if they're on diuretic, really, like you're not able to gauge from that. But, it might be helpful. Somebody walks in there, they have AKI, like you calculate the FeNA, and if they have less than 1%, probably they have pre-renal cause for, like AKI. And if they're more than 2%, then you can think like, acute tubular necrosis. But now, like, this is just a simple measurement, which could be helpful, which may not be really helpful there as well. And you can look into the other electrolytes. So metabolic acidosis could be also found with hyponatremia. So, patient might be in renal failure, or they could be adrenal insufficient, or they have lots of diarrhea or intestinal secretions, or their potassium could be normal, especially SIADH, primary polydipsia, their edematous because of heart failure or renal nephrotic syndrome, or pure cortisol deficiency or hypothyroidism. And you can have metabolic alkalosis if you're vomiting, or somebody's on NG suction, or they were overusing or abusing diuretics. So, and pseudohyponatremia, it could be seen with hyperlipidemia, which is very apparent with hyperlipidemia. So your correction, it is not apparent, sorry, because your correction factor is 0.002, so that they must be really high, like, to see that effect, but that can happen. Even with the hyperproteinemia, we don't see hyperproteinemia, especially in the kids. It's more of an adult disease, but like, yeah, maybe we might see, but the correction factor is listed here. And for hyperglycemia, we truly see this among the diabetics. So every 100 milligram per deciliter rise in glucose, you will see the sodium decreases by 1.6 milliliter per liter. Now let's talk about SIADH. So you have, inappropriate, ADH sub coming from it, either it's secreted or, yeah. So basically it's floating around, and, it's causing overwhelming, absorption of water and the dilution of the blood. So you have the hyponatremia. So in this situation, you have true plasma hyposmolality. So when you calculate that, you minus that urea, and then, you can calculate based on that. And your urine concentration, like, it's inappropriate for the plasma osmolality. So plasma is truly hyposmolar. At the same time, when you check the urine, it's high, basically more than 100. That means there is a disconnect going on. And clinically, they will look euvolemic. And those patients will not be on any diuretic. And you already see their thyroid function is normal. Their adrenal and kidney function, renal function is normal. So they are not in renal failure. They don't have adrenal insufficiency. They have normal thyroid function. And they're not on diuretic. Somebody, like, might have some reason to have inappropriate ADH secretion, and plasma is truly hyposmolar, urine is, inappropriate, meaning like urine will be hyperosmolar in contrast to the plasma. So in this cases, like, you normally, like, your ADH will be secreted when, your plasma osmolality is more than 280, and it goes up, about 290 and up, like it keeps on rising, right? Here, most of them, almost 85 to 90%, they were secreting, they had the elevated ADH, like way below whatever the normal trigger is. Treatment, if they are normovolemic, you can do the fluid restriction. And if you need to maintain the normal volemia, like if they're edematous or something, then you can do diuretic therapy. And at the same time, if you need to replace the insensible losses and hourly urine output, you can do with the normal saline in this cases. And use 3% sodium chloride for partial correction if they have some CNS symptoms. And mostly like, they might have slow symptoms if they're walking in your clinic, but in ICU setting, you might be using this. Outside ICU setting, like, probably ER might give 3% sodium chloride, but usually it's not done. First thing, like how do we raise the serum sodium and how fast we raise, those questions will come. Treat the underlying disease. We always have to identify what are the things that could be treatable. Is this the patient where we need to fluid restrict and that will take care? Or would this be patient where we're doing fluid restriction at the same time? Do they need the sodium, supplementation? Or do they need any vasopressin receptor antagonist? Those questions. So treatment of underlying disease, what you can do, administration of saline to the patient who are truly volume depleted. So those, you will give saline, otherwise, they will just, if you restrict, that's not the way to go for them. In this setting, once you restore your volemia, then ADH, that will suppress the ADH, release, and then they will basically excrete that water, excess free water. And if somebody comes in and they especially it happens to maybe BMT patient or renal patient where they're on steroid for a long time, and then their adrenal pathways it's suppressed, they walk in and they might be they're hypovolemic, hypoglycemic, and they have this acidosis, and they're you're okay, what's going on? But truly, in the history, they truly have something where they took their steroid for long term, and now they're in adrenal crisis. So in those cases, if you give them glucocorticoid, that will take care of this hyponatremia. So they can overcorrect. Suppose you're giving 3%, at the same time you're trying to correct your sodium, but when you give the steroid, sometimes there's a risk of overcorrection. That's why you need to monitor those blood work closely. And relatively rapid reversal of syndrome of inappropriate ADH secretion occurs with self-limited disease. Suppose they're having so much of nausea or pain, it could be post-surgical, period too. Suppose you address that, that will probably take care of their, inappropriate ADH secretion. And some of the medications, the SSRI, you stop it, that can also correct that underlying cause of SIDH. Fluid restriction, especially primary therapy for somebody who is edematous, heart failure and cirrhosis, or SIDH, and somebody with polydipsia or advanced renal failure. Hyponatremia, it develops over long time, so they might not have overt symptoms. So you might, just address the fluid restriction, and that could correct their sodium slowly. Sodium chloride administration. So if they were doing diuretics, right? So they are truly depleted. That means you might need to replace them with the sodium chloride. And if they're truly volume depleted, you need to restore with saline. And adrenal insufficiency, they will be the one who will need it. And some SIDH also needs it. And especially who are symptomatic and you don't want to drop that sodium too low, you will need 3% sodium chloride so that, you correct them. And salt loading would be contraindicated, especially edematous patients like heart failure, cirrhosis, even renal failure, somebody with nephrotic syndrome. If they're swollen, you don't want to give excess salt and then they're more swollen. Now, how do we estimate the sodium deficit? I think Dr. Blackburn already touched this. Again, sodium deficit is 0.6 is the distribution factor of that sodium in the extracellular fluid. So 0.6 times your weight and desired sodium, how much you want to raise, and what is your actual sodium, so that you can calculate and you can quantify how much you want to raise within that time frame, right? Our usual goal is to raise less than 10 milliequivalent per liter in first 24 hours. So if we do not exceed that, then you're good with that. And, around 18 to 20 within that first 48 hours. And for this, you will need serial sodium measurement. Hyponatremia and rapid correction. Overly rapidly increasing that sodium concentration can lead to osmotic demyelination, also called central pontin myelinosis, even extra, the central pontin myelinosis, extra myelinosis could be, can happen, but, this is devastating. Not that we would see often, it's very rare, but no, I haven't seen, but, that can happen. And for the normal brain, right, your osmolality is maintained immediately, like your body's tonicity is decreased. So what happens is like the brain cell will gain the water, and your brain will now, like as part of that, rapid adaptation, like, what you're doing is you're losing the salt, like sodium, potassium, and chloride. And then as part of the slower adaptation, you basically lose the organic osmolytes in the brain. That's how like the brain will maintain that, osmolality. And if you try to give a lot of hypotonic solution to these patients, then water will go in, and basically like, you're causing, like water will extrude out, right? So from that, because you're giving a lot of salt will go there. And, you're trying to maintain that, but at the same time, that will cause demyelinosis because, you're shrinking, and then, cause that rupture of that cell, which is swollen. Here, same thing, normal state. And, when you're acutely hyponatremic, body water is going in there, and you adapt with that osmolytes, and you aggressively give the salt, and then that salt load is higher in the periphery. So those, water from there, it's swollen, but water from there will try to go out, and it shrinks and, cause the myelinosis. Here, this the central area pons, this is the pons flare. Incidence is very low. I was looking, and, it's more of like, you can count the cases from 1960s until now, but, basically the risk factor was aggressive, the replacement, and they were looking into things like hypoxemia or anoxic episodes prior to their presentation probably was also contributing. And they have this locked syndrome kind of, and it can happen after, immediately, or, even after several days. And, most of them, they get better later on, but then they can have, intellectual disability or, other consequences as well. Symptomatic hyponatremia. So those we have to, correct it. The risk of untreated hyponatremia and cerebral edema is greater than the potential harm of that myelinosis. So we always, address this. And, as we calculate, what would be the safe number to raise that sodium, right? That's the question. So around 125, that's where, we see that demarcation where less than 120, probably you'll see all the seizures, and they're confused, and they might not making sense what they're talking. So you want to safely raise that level to safe point where you're not overcorrecting, but at the same time, keeping it safe. So around 125 is the number. And you calculate the sodium dose and how much you want to raise, probably immediately 5 milliequivalent per liter, probably that's the safest number to raise where, neurons are not firing anymore. And volume of 3% saline. So 2 ml of 3% saline is 1 milliequivalent of the salt. So the sodium, so you can basically calculate how much you want to raise and how much the delivery would be. So if we said 5 times 2 would be, 10. So, you just calculate based off that. But rough rule, if you go in ICU, they might be giving, 1 to 2 mils per kilo per hour. So they can correct over one, maybe 3 hours. But if they are constantly seizing, they might change that, correction within an hour, or they might just give a bolus of that fluid. So if like I just put this case, 10 kilo, right? They present with seizures and found to have sodium of 115. That's truly low, and their brain is swollen. That's why they have seizures. And you want to increase by 5 milliequivalent. So 0.6, like that's the distribution factor of the sodium times 10 the weight times 5 milliequivalent. That's the sodium you want to raise. So here 30 milliequivalent of sodium, if you deliver that to the baby, then their sodium would rise from 115 to 120. Provided the kidney doesn't do their different things, sometime it can happen. The volume, because we said 2 ml is 1 milliequivalent in that 3%. So you will basically give 60 ml. How you can give it, you can do it over a few hours, or sometime there is a situation where you might want to give it as a bolus too. Okay. So if they are swollen, definitely the aim is to control their fluid, like the whatever you want to restrict their fluid intake. So usually rough rule is like we don't go too much of a restriction with the kids because they need to eat, they need to grow if it is a chronic issue. But you can put it like insensible losses, which is closer to 400 to 750 per meter square. That's the range, plus the urine output, whatever the urine output they make it hourly, you can just replace that to the patients. And this is basically the dehydration, which Dr. Blackburn already covered. So I just put it here. Now we'll talk about the hypernatremia. So when you're losing more water than the salt, then you encounter this, like hypernatremia, or body is losing more free water, let's say, then you encounter hypernatremia. When serum sodium is more than 145, you call it hypernatremia. And in these cases, it's because you're losing more free water. It could be because your insensible losses are more. You're running marathon the whole day and you're not drinking as much, or somebody is in, like the kid who doesn't know what to do. They don't have access to water. They're left outside in very hot and humid environment, probably those, or severe diarrhea, or sometimes urinary losses, right? Or like somebody with intellectual disability who, one thing is they don't know how to ask, or they don't have access to the water. Even though they are thirsty, they can also have hypernatremia. And sometimes I had seen 2 cases where the formula was mixed with salt. So salty formula, and one of the kids, she presented at 3 months of age with sodium of 194. Yeah, the salt, and mother brought the formula. It's formula, but we tasted it was salty, and it truly was salt mixed in there. Nobody knows. She bought it from somebody. It was the patient from Del Rio. So, Mexican border. So we don't know whether they were doing it or somebody else, but kid relatively did okay despite, some of the complications, and later reunited with the parents after 2 years. Family members took over. And it can happen when they're getting lots of sodium bicarb, like somebody with acidosis, you're giving lots of sodium bicarb, they can also become, hypernatremic. Symptoms, same thing, lethargy, weakness, some irritability, and can progress to twitching, seizures, obtundation, and coma. And that's because, brain is shrinking, right? Because, lots of sodium in there, and that can lead to cerebral vein, like rupture and hemorrhage. Severe symptom usually, occur if there is acute elevation, and especially more than 158, and values more than 180 are associated with high mortality rate. And it's really difficult to correct when somebody comes in with that high of a sodium, no matter what math you do. And kidneys, once you replete, and she was dry to that patient, so it was a challenge to correct her as well. And suppose somebody walks in, their weight, they have decreased weight. That means, they're losing more, water, or they have increased weight, like they're losing more salt, like free water, but, like there's something going on there. That's why their weight is increased. So renal losses, sometimes nephropathy, like can cause this. And especially like, when the concentrating defect and all that, diuretics, diabetes insipidus, and diuretic phase of ATN, you're losing so much of the water, and you can basically see that. And extrarenal losses, GI losses with diarrhea, skin losses, especially cystic fibrosis, or you're exposed in extreme heat, and respiratory losses too. They're severely tachypnic. And sometimes it's just, as I mentioned, if there's a lot of salt load, that means, your salt is high, you're, adding, body is trying to conserve the water, but salt load is so much higher, you're not able to, balance it. So that can happen, like especially, exogenous salt or mineralocorticoid excess, like they're on prescription medication and there's a medication error that can happen, or hyperaldosteronism. They are also the one where like you basically adding more salt, water is being retained, so their volume overloaded, but they're still hypernatremic. And if you suppose, you're losing, from the kidneys, hypernatremia. So normal kidneys, if your kidneys are working okay, your body has a lot of salt, that means kidneys should be excreting a lot of salt, right? You check the urine, and if the urine is dilute, meaning like, or sodium is very low in the urine, that means kidneys are not doing their job. And in this case is hypernatremia, like you will replace the free water losses here. And as such, the osmotic regulation of ADH release and thirst, there's a term called a reset, osmostat for different people who are used to drinking more water or who are not used to drinking more water. But in general, osmolality more than, 280, around 290, you see the steep curve going up, your ADH release. And then around 290, that's where your thirst comes in, and then you want to drink more water, and you're adding more water, and then you try to, dilute that salt, and then ultimately, the kidney will take care of it. And if somebody is hypovolemic for some reason, like you see the ADH release, like, you should be severely like you're either you're severely dehydrated, or your blood loss, or, from burn, like you're losing like almost 15 to 20% before the ADH, level rises. And urine osmolality. So as you go up with the AVP level, your osmolality also, keeps on increasing. And even when you maximally concentrate your urine, that, like your vasopressin level probably will keep on rising too. And anything that increases the plasma osmolality, be it salt load, or, the other causes where you're losing more of free water, then, increased thirst and increased ADH will basically keep it in a balance. So anything that's deranged in between that two terms, somebody who doesn't have good thirst mechanism, or they don't have access to water, like infants, toddlers, or mentally like, challenged, those are elderly who don't have access to, things, they can be at risk of hypernatremia. And diabetes insipidus, right? You could have central diabetes insipidus, or it could be, ADH is there, but the kidneys are not, sensitive to ADH. So you can basically, like, what happens is like renal water reabsorption, like, with basically it will not reabsorb because of the lack of that ADH, or ADH is not working on the receptors, and then you make a lot of dilute urine. And, the ADH is secreted in the hypothalamus, and then it will be basically like, carried and then stored in the posterior pituitary. Here, I won't go with the central diabetes because it's apparent, right? You check and then your, like levels are low and then you know what to do. Like, but when, they're behaving like diabetes insipidus, but then their ADH level is high. And, next thing would be like, is it the kidneys which are not being sensitive to, things? So nephrogenic diabetes insipidus, it could be congenital or acquired due to various other, problems. And basically you have ADH, but that's not, working in the kidneys and you're not able to concentrate the urine. And if you see pituitary diabetes, your, ABP level is so low, despite what the plasma level is, but with the nephrogenic, diabetes insipidus, you see this ADH level is so high and still, your concentrating capacity is low. That's why, you're basically excreting all the, urine, which could be similar to plasma or a little higher or around there, but basically your concentrating defect is there. So normal concentration of urine depend on the, creation of hyperosmotic medullary interstitium, and primarily the sodium reabsorption without water in the ascending loop of Henle. Suppose, you knock this transporter with the loop diuretic, then you lose more salt, right? So that is water resistant, pathway. So there hyperosmotic medullary interstitium is created because you basically absorb all your salt around that area, and then interstitium is osmolar, and same thing with the urea, that also gives you the interstitial, osmolality. And osmotic equilibrium of the urine in the collecting tubule with the medullary interstitium. So here, hereditary, you could have, B2 receptor gene mutation. Usually it's X-linked in almost 90% of the cases. Or you could have aquaporin 2 gene mutation. So basically those B2, would be inserted, right? So somewhere there's a defect, which could be autosomal recessive or autosomal dominant. And there are lots of acquired causes. In pregnancy, you might have ADH secreted from that, impairment, and you can have that, but mostly it's placental pathology. And, and then they're so volume expanded, but, we don't know about the effective volume in their body. So, and drugs, especially lithium for the bipolars, and hypercalcemia, hypokalemia. So they interfere with the medullary concentration gradient. And acute and chronic kidney failure, sickle cell anemia. I know there's a big chunk of sickle cell patient in here, and they could have potential nephrogenic DI. And with the renal failure, there will be inability to concentrate the urine maximally, it can happen. So osmotic diuresis resulting from increase of solute excretion in the remaining functioning nephrons. So it's more like, some nephrons will be hyperfunctioning, and decreased tubular responsiveness to ADH2, because those receptors, however they would be inserted, that mechanism is altered too. And you can have this interference with the countercurrent mechanism, and that affects the renal medulla, especially true with chronic pyelonephritis with the scarring and analgesic overuse nephropathy as well. As the CKD progresses, your concentrating ability also decreases. One thing is scarring, the nephron number will be less, and they can have polyuria. That's because, one thing is dysplastic kidneys, their tubules are so immature, they will lose. And if it is scarred, they won't be able to excrete as much, because whatever the functioning nephron, they're so limited, and you're basically destroying all the nephron number, and they don't. And with the sickle cell, you have diminished concentrating ability, because, the sickling is in the vasa recta. And initially what happens is there's a low oxygen concentration in there. And, with the sickle cell disease, you're sickling around that area, and during that process, you lose that, countercurrent mechanism. It basically interferes because of the sickling. You slough that, papillary as well sometimes. So similar thing. And they, over time, they have the concentrating defect. And, hypernatremia could be because it might be transient because of water loss into the cells, especially exercise, during the time of seizures. And, that's pushing, that water into the cells. But mostly you lose because, kidney is not doing good job, or insensible losses are so much more. So what you have is increased sodium, like plasma sodium. So obviously your osmolality is going up. And, so water, when you're so, hyperosmolar in the extracellular space, so the brain will shrink because water is extruded out, and you are risking this subarachnoid hemorrhage. And even the cerebral venous sinuses might be thrombosed too. And these are possible irreversible neurological damage. So, and this is true, especially when your thirst mechanism is impaired, or exogenous, especially for the younger children, they won't be able to tell. And cerebral adaptation, so same thing here. Beginning on the first day, brain volume is largely restored due to water movement from CSF into the brain, and uptake of solutes by the cells. And then same thing, like the osmolytes, will be coming in. So if you see this brain water, right? So when you lower, your sodium increases, right? When your sodium increases, if it is within 1 hour, you're shrinking, and within 4 hours, you shrunk a lot. But over 7 days, it's sort of normalized back to what it was, like when it was 170 compared to 180. So you adapt over several days. That's why when we say diarrhea, when did that happen and how long this kid is dehydrated? So if they're acutely volume depleted, your management might be slightly different than when they're chronically depleted as well. With the chronic hypernatremia, they will be normal looking, and you will correct that slowly as well. And especially happens to those with the underlying neurological condition, especially diminished thirst response. And, rapid correction, if you do that, they will have, cerebral edema, and that can lead to seizures and coma. Hypernatremia in hypovolemic patient. So basically they lost a lot of free water, because one could be, they're sweating and they're febrile, or, it could be a cystic fibrosis patient with, ongoing diarrhea and urinary concentrating defects, such as, diabetes insipidus. Even those patients could be sick with something else, right? And they can lose much more water. And, if you have relatively dilute diarrheal gastroenteritis, then also you see the hypernatremia and they're hypovolemic. And in those cases, you can still do the normal saline bolus though to restore their volume. But ultimately, you will do slower, unless they are they're dry and their blood pressure is low, they're tachycardic, you can do the slow correction with dehydration as well. And, if you correct too rapidly, they will have neurological sequelae, especially like 155, 160, somewhere there. You want to slowly correct it. And your correction rate, you can keep it less than, 0.5 milliequivalent per liter per hour. So in a day, if you aim for less than 12 or, around 10, that would be probably, safer to do. And what would you do is free water deficit, you have to calculate, and then ultimately delivery of the electrolyte would depend on how soon you want to correct. And free water deficit, similar way like how you were, calculating the other deficit, so 0.6 times weight. And what amount you want to correct, right? What is your, serum sodium, and how much you want to correct, that will also depend. So roughly saying, like, if you want to correct, 1 milliequivalent per liter, you will be giving 4 ml per kilo of that free water. So that volume will be needed to dilute that, solute and bring down the sodium by 1 milliequivalent. So suppose you give 4 ml per kilo, somebody's 10 kilo, so 40 ml, to a kid, 40 ml of D5W, then you might reduce that sodium by 1 milliequivalent per liter. So here, this is the calculation I did: 10% dehydrated and have sodium of 156. Your total fluid deficit, because if he's dehydrated, he might have lost some free water plus the electrolyte water. So you calculate the total fluid deficit, which is 10% of 10 is like almost a liter, and free water deficit, like that's based off that 0.6 distribution factor. So 6 liter, 0.6 of 10 times, your serum sodium is 156, you want to correct to 140, right? So that's where, suppose you want to correct to 145, then you would be doing 145 there. And -1, so you got that 686, that's like a free water deficit. And from there, they have some extra, salt water, loss as well. So 314, you can get, that would be more like isotonic loss. They lost some solute as well. And as always, when you have to resuscitate, no matter, whether you're hypernatremic or hyponatremic, a normal saline would be safer to do. And once you restore the volume, then you can slowly, correct that dehydration, slowly correct the sodium based off, how soon that was, depleted. And if it is chronic, don't overcorrect it. Any questions? Mm-hmm. If they are truly hypernatremic, you can do that. Yeah. But anyways, you're, checking that sodium again. So you restore the volume, that would be more important, right? And at the same time, you don't want to drop it too low, or you don't want to raise it too high. So that would be okay. But, don't give too much of that, hyposmolar load as well, so that, you're depleting, too fast. Because sometimes what happens is, when you're truly hypovolemic, your ADH is also acting. And then once you restore the volume, that action will go out. That's where the kidney will try to conserve things which are not in your calculation, and then you might overcorrect. So, checking when you're repleting, checking your sodium every 3 to 4 hours makes sense, just because you're not overcorrecting. And that will be true to those with the adrenal crisis, because my observation is, you want to give 3% because they're seizing, yes, but then you give the steroid on board, and so stress dose will do the magic, and they start correcting so fast. Like, they might come with 120, and then next morning, over 12 hours, they might go to 140, which is not what you wanted to intend to correct, but truly that can happen. But those are not the chronic kids, so probably you didn't do much of a damage there, but you don't want to correct by 20 factors as well. Yeah. And with the SIDs, yes, we said, volume restriction, but sometimes they are the one who will need the salt loading as well, even though we know, maybe they won't need it, but, yeah, especially if they're symptomatic and you have hard time, restricting fluid, and all the fluid, whatever is going in, could be normal saline, but normal saline will not do the magic, because, in order for the kidney to, excrete that excess, water, then you will need 3%, because you give a large volume of a normal saline, then only they might, excrete, but you'd give the salt, but, you're adding more water with the normal saline compared to 3%, where salt load is much bigger than compared to volume. so that you're not giving a lot of extra water. You give a lot of salt, so that will take care. And then, like, yeah, quickly, and you start losing more water and you kind of correct. Sometimes adding more salt and with the isotonic solution, you might risk them with more swelling and then they don't pee. If they're edematous, and obviously, like that would be more of a cautious. Sometime what you can do is like you can give them even the hypertonic solution and then diuretic to get rid of the extra fluid. So it's like sometimes you just have to adjust. But yeah, so if they're edematous, definitely they might need the diuretic on board as well. But it's more of a caution, not only isolated diuretic, you might be giving salt and then, taking care of that extra one as well. Yeah. But mostly like, if it is chronic, then, you take care of that with the fluid restriction. But ICU, like sometimes it's difficult. Yeah. I think the audience, it's hard to, ask the question. And I think it's hard to even follow the lectures like this, which are more complex. So I don't know. Any questions from audience, or you can email me if there's any clarifications or anything. You're welcome.
Yeah. Yeah.